Hello everyone, we are here at Georgia Chiropractic Neurology Center. I am Dr. Cassandra Jimenez, and today we're going to be talking about tics, what they are, and how can we help. This is our team in Georgia Chiropractic Neurology Center. We are 7 doctors. The lead is Dr. Mark Ellis. He was the founder. He's the founder of the clinic. We all have our own specialty. We mainly work with patients with anxiety, concussions, patients with vertigo, dysautonomias, POTS, orthostatic hypotension, kids with neurodevelopmental disorders, and other neurological conditions. As I said, I am Dr. Cassandra Jimenez. I'm going to talk a little bit about me before starting the presentation. I am a chiropractic neurologist, so I graduated from the chiropractic school, and I have a diplomate of the American Chiropractic Neurology Board, and as well I have a fellowship of the American Board of the Vestibular Rehabilitation. I'm a lead clinician here at Georgia Chiropractic Neurology Center. Have been working here for around 4 years now. And I also have the pleasure of being an adjunct professor at Life University, where I teach classes like neurodiagnosis, neuroanatomy, and other techniques. I have also had the opportunity of being a contributor and author in the Concussion Discussion book. And also I have abstract publications in the journal Frontier of Neuroscience. The purpose of this talk is to help you understand what tics are and their different causes and how we can work together to manage them. So how can we help if you have somebody that is suffering with tics, a tic disorder like Tourette syndrome, for example, we are able to help them, and we're going to be able to understand better what it is and what do we do to help them. So tics are a very common symptom of hyperkinetic movement disorders. They are described as sudden, repetitive, rapid, non-rhythmic, and stereotype involuntary movements or vocalizations, productions involving discrete muscle groups. So it can be either vocal or it could be motor tic. Tics affect up to 50% of the general population at some point of their life. So 50% of the people around you might have a tic at some point in their life. As I said, they are split into 2 groups, motor and vocal tics. Motor tics are usually begins first in the head and the face in the early childhood. So motor tics, you can see them, the onset is around 5, 6, 7 years old. And over time, they may start to progress from the head to the neck, to the shoulders, arms, and torso. Some examples, and the most common one that we see, are eye blinking. Other ones are eye rolling, facial grimacing, mouth movements, shoulder shrugging, nose wrinkling, or head twitchings, or lip biting. Those are some of the most common ones that we see. The vocal tics, the onset is a little bit later in life. This happens around 11 years old. And the most common ones are coughing, nose marks, wheezing, whistling. If you see people like clearing their throat, like doing this sound like it's considered a vocal tics. Barking, it's an example of a loud noise. So the loud noises are also considered part of the vocal tics. When we first split them into motor or vocal tics, then we have 2 different types. We have simple and we have complex tics. The simple tic is considered a quick, brief, involving one muscle group or a single sound. So it's just one tic. And examples, as I said before, eye blinkings, shoulder shrugs, throat clearing, sniffing. Those are examples of simple tics. We also have what we call complex tics. These are more coordinated patterns involving multiple muscle groups or longer speech. This one, you can see touching an object, repeating words, jumping, facial expressions with movements. Those are examples of complex. So you have a tic, then first we need to decide, is it a motor, is it a vocal tic, and then we split them into simplex or more complex tics. When we talk about complex tics, these are some examples are what we call copopraxia. This one is an involuntary performance of obscene or inappropriate gestures. This is common in 3 to 12% of patients with specifically with Tourette syndrome. The severity of the tics has been documented to increase mostly when the patients are stressed and when they are fatigued or very excited, and it calms down when they are either have mental or physical activity. And we use that in our treatment. So we use a lot of physical activity, a lot of mental task, because we have noticed that when they are engaged, those patterns, the tics decrease. So we use what we call neuroplasticity to help decreasing those tics in those scenarios. Another one of complex motor tics examples are echopraxia, which refers to the automatic imitation of movements or actions observed in others. So we have copopraxia and echopraxia. On the right side, I put a picture. In the first picture on the left, top left, you see a child with common simple and motor tics like shrugging the shoulder and wrinkling. On the top right, in that picture, you see an adolescent with a combination of complex motors like pulling the hair and a complex phonic tics like saying don't trip, don't trip, don't trip, and an emerging behavior features including ADHD. So we're going to learn later that there's different comorbidities to Tourette syndrome or tics disorders, and ADHD is one of them. On the bottom left, you see an adult. So it's less common to see patients that are adults with tics disorders, but in here you can see an adult with a tic disorder. And on the right, this image was put in there because, again, we also, even though the tics are less common when you're adults, there's different comorbidities that are more increased. For example, OCD patterns. In here, he is obsessively like snapping the fingers or scratching the head and humming repetitively. So you can either see the tics when you were young, you can see them when they're adults. They are less common, but you can see more the comorbidity like OCD in that population. In complex vocal tics examples, we have one that is called palilalia, which is an involuntary repetition of one's own word or phrase, often with decreasing volume and increasing speed with each repetition. So you say one word and then you repeat your own word after that. We have echolalia, which is the automatic and often involuntary repetition of words or phrases spoken by another person. So somebody says, car is red, and they say, car is red, car is red. So they repeat what the other person said. Corpolalia is the involuntary outburst of obscene words or social inappropriate and derogatory remarks. This is very common in Tourette syndrome. 10% of the patients have corpolalia. And we also have making animal sounds as part of the complex vocal tics. Those are 4 examples of what we consider complex vocal tics. There is something that is called premonitory urge. This is when the patient reports discomfort or a feeling of pressure before having a tic. This helps and is very useful when differentiating or have a differential diagnosis of myoclonus, or you have a functional jerk, or you have any stereotype of mannerism, because that urge is very, very common in patients with tics. After they perform the tic, they feel a relief after that accompanies the successful execution of the tic. So they feel that urge, and then once they execute the tic, they feel more calm. So on this image on the right, you can see the patient has the premonitory urge, which is the sensation of discomfort. You start having the muscle tension increase, and then suddenly, once you elicit the tic, you feel feel calm, you feel a sense of relief until there's another cycle coming. So this is something very common on patients with tic disorders, and that's what separates them from other movement disorders. There's 3 tic disorders that are very common in the DSM-5, which we're going to talk later about it. But the most common that we see is Tourette syndrome. This is have specifically both motor and vocal tics, but you have multiple, 2 or more motor tics and at least 1 vocal tics. But these tics last for at least 1 year. Persistent motor vocal tic is a different subgroup, but this one is more, you have either a vocal or motor tic that lasts for at least a year. So in Tourette syndrome, you have a combination of both. You have more than 2 motor tics and at least 1 vocal tic for at least 1 year. But in persistent motor or vocal tic, you can have 1 vocal or 1 motor that persisted for at least 1 year. So that's the difference between the first 2. We also consider the provisional tic disorder, and that is tics that either are motor or vocal or both, but that have been present for less than a year. So those are what we call provisional tic disorders. After COVID, or during the COVID pandemic, there has been an increase of adolescents or young adults with something that we called functional tic-like behaviors. They started after they spent too much time on their computers watching YouTube videos or TikToks while they were mimicking patients having tic disorders or vocalizations. This is very, very different than Tourette syndrome because it's more abrupt and it has a later onset of symptoms, and it has an absence of symptom fluctuations, and it's higher. The prevalence is higher in females than males. While in Tourette syndrome, we're going to learn later that the motor tics or the vocal tics, you see them more on males versus female. The ratio is a little bit higher in males than females. We are going to be focusing mainly on Tourette syndrome because that's one of the most common tics disorders that we see here in the clinic. This is a chronic neurodevelopmental disorder. It's, as I said, characterized by motor and vocal or phonic tics. And this unfortunately can diminish the quality of life of the patient because they don't want to get involved in a lot of social settings because they feel embarrassed because they're having tics. Mainly when we are in an era where there's a lot of bullying. So when they're in the school and they're having these tics disorders, they get bullied because of it. It's around 0.3 to 0.9% of school-age children, around 4 years to 18 years old, experience or were diagnosed with Tourette syndrome, and 0.002 and to 0.08 of adults have that diagnosis. So it's way, way less once you're an adult. Tourette syndrome occurs more frequently in males, so there's a 4-to-1 male to female ratio compared to other tic disorders. The etiology of this condition, it has a very strong genetic influence. So there's different researchers that they got a pool of patients and they saw that they got patients with Tourette syndrome, 77 to 92% of those patients had a genetic mutation or a gene that was directly related to Tourette syndrome. Other influences are pre- and perinatal problems. Repeated streptococcal infections are other causes of it, and autoimmune dysregulations. Autoimmune dysregulations contribute to the pathophysiology of OCD, Tourette syndrome or TS, and also what we call PANDAS, which is pediatric autoimmune neuropsychiatric disorder. It's not the same, so those are completely not the same, but you can see them very often in those three conditions. When we talk about Tourette syndrome, there are different comorbidities that comes with the Tourette syndrome. So if you see a kid with a tic disorder or Tourette syndrome in this case, you might see that they have a OCD, ADHD, anxiety, some depression, because of the pathophysiology involves very similar regions in the brain. 90% of these patients present with comorbidities. If you see on the picture, you have, as I said, the ADHD, the OCD, and other behavioral problems or poor impulse control. Comorbidity occurs in about 90% of these patients, as I said, and only 10% of Tourette syndromes alone don't have any other psychiatric disorders. So 90% will have other comorbidity, 10% will have only Tourette syndrome. Let's talk a little bit about pathophysiology. What's happening in the patient's brain that is causing the Tourette syndrome? And in order for me to explain this, it's super important that I explain what the basal ganglia is. So the basal ganglia, think about it as your brain's movement manager. It helps you start the movement, coordinate it smoothly, and stop when you are done. So in Tourette syndrome, these movement circuits can get a little bit out of tune, and which may cause the body to send signals for extra unwanted movements. These are what we call tics. Inside the basal ganglia, we have a part of the brain that is called the striatum. So the striatum is the traffic hub of movement. One important part is it's like a busy traffic hub that receives information from many parts of the brain and then sends signals for like a green light or a red light, depending on what movement you want to perform. So if you want to stop or if you want to go. So we also think about the basal ganglia striatum as the gas on the pedal. In Tourette syndrome, research has shown that in some TS patients, a part of the striatum called the caudate specifically, nucleus may be smaller, and sometimes this relates to how intense or frequent their tics are. So we know that in Tourette syndrome, we have the basal ganglia, specifically inside the basal ganglia, we have the striatum, and now we're going to be talking about the dopamine, which dopamine is what we call the chemical messenger. Dopamine is one of the brain's main chemical messenger for movement. And in Tourette syndrome, dopamine signals may be out of balance, so they might be dysregulated, which can make the movement control system more excitable and more likely to produce the tics. And why all this matter? Why do we need to know? Why it is important for us to know what parts of the brain are the ones that are affected in Tourette syndrome? Because that's going to affect how we treat the patient. So by understanding how these brain systems work, help us design strategies like specific exercises or reflex modulations and sensory-based therapies that can help retrain the brain's movement pattern and reduce the intensity of the tics. So we take our physical examination, we assess the different parts of the brain that might be affected based on what we know of the research and the pathophysiology of the condition, and then we create specific treatments for that patient to help the tics calm down, or if you have different movement disorder dystonias. So we help the different patients by knowing all the anatomy, all the pathophysiology of each condition, and that's what is happening in Tourette syndrome. This is a review of what I just said. So the pathophysiology, and here in the picture you can see also, in pink you see the basal ganglia. You see the thalamus, which is very related to the basal ganglia, and there are also the frontal lobe. Those three systems are very, very tied together affect and influence movement. The pathophysiology is characterized by an excess of dopamine or hypersensitivity of the postsynaptic dopaminergic receptors at the basal ganglia level, so which is the part of the brain that I explained earlier, with a consequent imbalance of this specific circuit, which is very, very well known in research, which is called the cortical striatum thalamus cortical circuit. So if you see, all that loop might be affected in some regions, and it's very important for us to know which regions are the ones that are affected, or which regions can we modulate to help the patient respond better to treatment. So the American Psychiatric Diagnostic and Statistical Manual of Mental Disorder, or better well known as the DSM-5, specify how to diagnose the Tourette syndrome. So the diagnostic criteria for Tourette syndrome is, and we have mentioned a couple already, is both multiple motor tics and at least one vocal tic. This needs to be present for more than a year, and you need to have the onset of the symptoms before you are 18 years old. If it's after, we don't consider it as part of the Tourette syndrome. The disturbances is not attributable to a physiological effect of some substances or another medical condition. And as I said, and as we mentioned before, you can see comorbidities with this presentation, like OCD, ADHD, depression, anxiety, and other behavioral conditions. There's several rating scales that we use on these individuals for the tics. This specific, the one that is the most common one that we use, is the Tourette syndrome of Jail's Global Tic Severity Scale. That's one of the most common scales used to rate the tics. Sometimes with these patients, unfortunately, the diagnosis can be delayed 3 to 11 years after the symptoms onset. And it's estimated 73% of the patients receive an initial misdiagnosis. So it's very important for us, and that's why we do this type of lectures, because it's very important for patients to be more educated and what the different conditions are. And if you're able to cut it earlier and you're able to be more educated on different conditions, you're able to seek help earlier, and you're able to help that patient's quality of life sooner. Unfortunately, there's no cure for the tics disorders or Tourette syndrome in this specific condition. It's more about managing the symptoms. A prospective study follow-up suggested that 17% of patients will experience complete remission after the age of 16 years old, and 60% will still experience some persistent mild to moderate tics. Up to 23% of patients will have persistent, and in some cases, severe tics into the adulthood. So even though when you're younger, it might not be, there might not be a specific treatment, there are options to manage the symptoms. And some research have found that after you are 16 years old, in some cases, the tics completely resolved, or sometimes they decrease in frequency or intensity, or in other occasions, unfortunately, the tics gets a little bit more severe. Established treatments right now for Tourette syndrome are behavioral therapy, medications, and other treatments that are emerging right now are more non-invasive neuromodulations, or they have been experimented also with deep brain stimulation. So those are the treatments that medically are out there for patients with tic disorders, specifically Tourette syndrome. But how can we help here at Georgia Chiropractic Neurology Center? What can we do to help patients with tics and Tourette syndrome? When you come to the office, we do a full neurological examination. It takes around 3 hours. We start with a history intake. We then do a vital assessment, We have something that is called a concussion baseline. It doesn't matter that you had a concussion. We use it to create a baseline of where our patients are. And then later on, after we do our re-examination, we repeat the test to see how much we have improved. We use it also as our cognitive testing, so part of it. It's very important for us to do an eye movement examination because your eyes are the window into your brain. So we know all the pathways. At the same time we know all the pathways causing the conditions that you're coming with. Let's say, for example, the pathophysiology for Tourette syndrome, which involve the basal ganglia. We know how the basal ganglia can affect eye movements, and we use the eye movement testing to see how they are affected and how can we help that patient by doing eye movement exercises, other therapies to target the areas of the brain that are affected. We also do balance testing, and we do a full comprehensive neurological examination. On the right side, you see me putting the goggles on one of our patients, and those are infrared goggles. That's called a VND, or video nystagmography, or video oculography. And what we do is we see different type of eye movements, like in dark, gaze fixation, pursuit, CCAT, OPK. And then, as I said, we know the pathways that control those different eye movements, and seeing how the eye movements are on our different patients, that can help us pinpoint areas of the brain that might be defective. My goal in my physical examination when I have a patient with tics is to find a test or changes in the environment that can decrease the tics presentation. So, for example, we go over all your lobes of the brain. We test all your cerebellum, which is the part of the brain that deals with coordination. We check your mental state of evaluation, your cranial nerve, your eye movements, as I said before. In kids, in patients with neurodevelopmental disorders, we see a lot of patients that have a lot of sensory issues. So we do a full sensory examination, motor examination, and muscle testing to see how is the integration of those systems. Coordination and gait, the reflexes, pathological reflexes, and at the end, specifically for patients with neurodevelopmental disorders, we test for preliminary reflexes. Preliminary reflexes, if you don't know what they are, those are reflexes that are developed in the womb, and they are present when we are getting out of the womb for survival. So let's say if you do a stroke on this side of your cheek, you tend to move, or the kid tend to move the head. If you stroke the patient's palm or the kid's palm when they are very young, like let's say 1 month to 4-6 month old, they close the fist. So those are for surviving after we are out of the womb. What happens is, once your brain starts to develop, you're going to notice that this reflex starts to get inhibited. So that's the reason why we are bipedal. So the frontal lobe starts to develop, all those areas starts to be inhibited, and then we start getting more extensor tone, which allows us to be bipedals, allows us to inhibit all those reflexes that we don't need anymore. What we have seen is with patients with neurodevelopmental disorders or even Tourette syndrome, we have seen the presence of different preliminary reflexes. So as part of our physical examination, we're not going to only see the motor responses, sensory examination. We're not going to only check the eye movement of our patients, but we're also going to check the different preliminary reflexes on our patients. Once we do the physical examination, one thing that we making sure is every time that I talk to a patient, so for example, I had a patient with a tic disorder. She was around 16 years old. She had a complex tic disorder, but she didn't have any vocal. What I noticed during my physical examination was that every time that I was talking to her, all her tics decreased. So in my examination, I targeted, and I noticed that the frontal lobe, which is the part of the brain that deals with cognition, processing speed, and it deals with movement as well, was a little bit affected. So in my treatment, I started doing a lot of cognition. So the patient had to think about saying words backwards, or I gave her an ABC, and they had to tell me a word with each of the letters, or we had to incorporate a lot of movement into our treatments, along with other therapies that we do. So by a couple of weeks in the treatment, the tics of the patient were completely gone. Now, it's not the same for each of patient. Every patient that presents here are different. They have different functional lesions, and these functional lesions respond different to the treatments. But in this case, we were able to help this patient pretty quickly. And after a couple of months, I talked with the mom, and she was completely tics free. As I said, our main goal at the beginning is not to get your patient or your kid or your family member or the patient that you know from having tics every day to zero. But my first goal and my main goal is to improve the quality of life of that patient. So when they are in stressful situations, they don't get as many tics. Or let's say that they in the daily life, instead of having 10, 15, 20 tics per minute, or maybe 10, 15 tics per hour, that decreases to maybe 10, 20 during the day. So if we're able to do that for our patients, we feel good, because that's one of our main goals, to improve the quality of life of our patients. In our rehab, we include different therapies. So one of them, we talk about the primitive reflexes. So if you do have a primitive reflex, or if your kid has a primitive reflexes in there, we might do primitive reflexes remediation exercises. We do a lot of core or coordination training depending on the patient in my physical examination. We incorporate a lot of vestibular rehabilitation, balance training, eye movement exercises. Depends on my eye examination. We do laser therapy, craniosacral work, cognitive training, as I said, for that specific patient. The cognitive task help decreasing the tics, so I might incorporate that on the treatment if the patient responds well to it. Visual therapy or light therapy, auditory therapy, those are other things that you might see. We have something that is called the metronome. If you see on the right in the picture, I am with the patient, and he is using the metronome, which is the patient needs to clap, in this case, at the same tone of the beat. And then when they see the chart, you're going to see that the chart is going to tell you if you're going too slow or you're going too fast. And the patient needs to use that visual feedback to change the motor pattern or the movement. This was developed mainly for patients with ADHD, but we have seen a really, really good treatment applications for different conditions like Tourette syndromes, for example. And we also do myofascial work, depending if sometimes like you have patients that have like very tight neck or the shoulder because they're having persistent tics. We might add a little bit of myofascial work depending on the case. These are the primitive reflexes that I mentioned earlier. I wanted to add the list in here so you can see the names, and then you can research it later. We have other lectures about neurodevelopmental disorders, so I encourage you to go and watch them in our YouTube channel, and they go a little bit more in depth on primitive reflexes. And we also not only help patients with Tourette syndrome, but we also can help a lot of patients with different conditions like neurodevelopmental disorders like ADHD, autism spectrum disorders, Tourette syndromes, OCD, dyslexia, language or reading disorders, patients with cerebral palsy or central auditory processing disorders. So this is an umbrella. So we are able to help patients with a wide spectrum of conditions. So Tourette syndrome is just one of the neurodevelopmental disorders, so we encourage you, if you know people that are suffering or they're having kids, or you know anyone that have autism or ADHD or are suffering with tics, they don't need to be suffering with those type of conditions. They can come and we can help them improve their quality of life. So this is my presentation. If you have any questions, or you want to have a free consult, you can always call us at 770-664-4288, or you can email the office, and we're going to be more than happy to schedule a free consult for you, or explain what we do a little bit more in depth. You can also come to the office to see the office and meet all the doctors. And if you have anyone that is suffering about not only tics or Tourette syndrome, but other conditions, again, just send them our way, and we are going to be more than happy to help them. Thank you so much, and I'll see you in the next one.